Your participation is important.
Good morning and welcome to yet another edition of The Burning Issue. This one is a Thursday and we are grateful to be back, and sincere apologies for starting our program late. This is due to the fact that our guest was running out on time due to circumstances beyond his control, and we are grateful that he is finally here and we are. So I would like to first and foremost welcome all of you to the happy world of 5FM radio here in Lusaka on 89.9 and the surrounding areas. And of course, we are also live on our partner stations. Tuta FM in Mansa on 90.7 is carrying this program live, and we are grateful for that. Muchinga Radio is live on this particular program today on 88.1, that is in Chinsali, covering the rest of Muchinga province. We are live also in Kabwe, and of course covering Central Province on 91.1, that is on Spice FM radio. Copper Belt is tuned in, and we are live on iWave FM radio, that is on 90.4 FM, and of course covering the rest of Copper Belt, like I said. Southern Province is well taken care of as well. We are live on Wave FM on 98.7 in Mazabuka, and of course don't forget to catch us live on Eagles as well. We are live on that platform this morning, and live on our Facebook page as well, that is 5FM Radio Zambia. I'm your host. My name is Zachariah Banda. Now, today we have quite an interesting conversation, and this conversation will definitely be one that will require that you too takes part in it, and because we will open the phone lines a little later so that you can have an interaction with our guest. We'll discuss many other issues surrounding the health sector, but first and foremost, let me just take you back to 2018, all right? And in 2018, consistent with the Global Task Force on Cholera Control goal of ending cholera in endemic countries, which is articulated in the Global Roadmap to 2030, Zambia actually sponsored the resolution to eliminate cholera globally by 2030 at the 71st World Health Assembly. Further to that, Zambia took a bold and ambitious step to eliminate cholera in Zambia by 2025, ahead of the global target. And of course, Zambia, to that effect, developed its first country multi-sectoral cholera elimination plan, which was obviously meant to be between 2019 and 2025. We'll be finding out whether we are on course with that plan and many other sector issues that we'll discuss on my agenda. I have also NHIMA to be discussed. I mean, are we on course with it? What was also the essence of establishing it, and how it's also implementing its mandate? All these will be unpacked in our discussion today. My guest to that effect is Honorable Dr. Chilufya. He is a Member of Parliament for Mansa Central and also former Minister of Health. Always a pleasure to have you on our Burning Issue program, and welcome to it, Doc.
Thank you very much.
Happy New Year.
Happy New Year to you too, and thanks, and good morning to all the listeners.
Great. How is Mansa doing, and the people of Mansa?
Well, I just traveled from Mansa.
Yes, you just arrived from there.
Exactly, and I apologize for coming in a little bit with the bereavement.
Okay.
One of our prominent members, Rachel Cholera, passed on, and we had to give her a decent send-off. And so we buried her yesterday. May her soul rest in peace.
Indeed. So, but then, how would you describe Mansa Central? Are we on course with regards constituency development?
Well, Mansa Central constituency has had a very consistent and a consistent work plan or roadmap for development.
Right.
So we embarked on a program in 2013 to ensure that all our children who are eligible get access to education, universal access to education.
Right.
We also focused on the health of our people in the constituency to ensure that everyone had access to health service delivery. We embarked on a program to improve infrastructure for our people in terms of markets,
Right.
roads, and we also decided to focus on agriculture and our road network. And so, in a nutshell, we are firmly on course in addressing matters to do with education, health, agriculture, road and market infrastructure, youth and women empowerment. So we are posting deliverables. We continue to post deliverables since 2013. And I believe that Mansa Central is on the right trajectory for development. There are challenges. There is improved CDF. There is increased CDF.
Yes, yes.
Yeah, there are challenges in the implementation, and these are matters that we need to address urgently. The pace of implementation, the bureaucracy, the human capital at the council, and just the pace at which we implement these CDF approved projects need improvement. And these are challenges that we need to address. It's in good faith that this new Dawn government increased the CDF,
Right.
and this in the spirit of decentralization. But this can amount to nothing if we do not address issues of efficiency at local government level.
Indeed. Great. Now, you were Minister of Health at the time when Zambia took that bold and ambitious step to eliminate cholera in Zambia by 2025, ahead of the global target. What necessitated this bold move?
Cholera continues to be a global public health threat.
Right.
And Zambia has not been excluded from this challenge. By the year 2019, cholera affected more than 2.9 million citizens of the globe, and more than 95,000 deaths were recorded globally.
Right.
When we zero down to the national situation, Zambia recorded its first cholera outbreak in the year 1977, and we have so far had 29 outbreaks. Now, this could be the 31st outbreak. Yeah, so now, if we analyze the ferocity of these outbreaks, you realize that the major outbreaks we had were in 1991, 92, 99, and 2004. I call them major outbreaks because these recorded more than 10,000 cases. Almost the highest could probably have been around 13,500. The next major outbreak was in 2017, 2018, but we recorded 5,935 cases with 114 deaths. This current outbreak today threatens to be the worst in the history of this country. Now, cholera is both preventable and treatable. Cholera is a diarrheal disease caused by an organism called Vibrio cholerae, and it is spread through, or it is contracted through consumption of contaminated water and food. And therefore, when you are talking about elimination of cholera or control of cholera towards elimination, we must address the primary causes of cholera. So what motivated us to move towards control and elimination was that we knew what the determinants, the causes of cholera were, the determinants or factors that fueled cholera outbreak. And these are within the control of government. If you look at the statistics of people who were getting affected with cholera, the deaths, the impact on our economies, it was important for government to take the lead, not only at national level, but globally, to push towards control and elimination. Yes, indeed, after the 2017-2018 outbreak, we did sponsor a resolution at the World Health Organization to eliminate cholera. And this resolution was adopted. And we even brought our target to earlier, to 2025. Now, Zach, cholera is caused by consumption of contaminated water or contaminated food. We can eliminate it through one major sustainable development goal: universal access to clean and safe water, and improving sanitation for all. So Zambia embarked on a program to, one, embark on a multi-sectoral approach to address all the determinants of the cholera outbreak, upgrade slums to ensure that we have households that have access to clean and safe water, ensure that good housing is in place, ensure that sanitation is addressed, that people are adequately sensitized on the need to consume safe and clean water and safe foods. The approach was multi-sectoral in nature because the Ministry of Health may not address all the determinants of health. Primary health care demands that we address water and sanitation, nutrition, housing, education, infrastructure. These are not under the Ministry of Health. So there is need to summon everyone onto the table to address every aspect that determines the health of our people. And that's the reason why we adopted a multi-sectoral approach. To eliminate, to control and eventually eliminate cholera, there was need for us to pursue universal access to clean and safe water. We needed to upgrade the slums within the urban areas. We needed also to ensure that access to clean and safe water, even beyond the hotspots, was also addressed. Critically, infrastructure, housing needed to be addressed. These are long-term measures. In the immediate term, we needed to ensure that we protected citizenry from the hazards of cholera. How do you do this? One, you need to map the country, define the epicenters and the hotspots. The hotspots for cholera in the country are around 14. They're in the peri-urban, overcrowded peri-urban areas in Lusaka and the Copper Belt. They're in the fishing camps. We need to ensure that we address aspects of WASH, that is water and sanitation and hygiene in these areas. Secondly, we need to improve sensitization of the public in these areas on the use of clean and safe water, chlorinated water, boiled cooled water, use of food that is well cooked. Thirdly, because we do know that the upgrade of the infrastructure will not happen overnight, there would be need to protect them through the oral cholera vaccination. Oral cholera vaccination confers 3-year immunity if you use it appropriately. The UCO vaccine that has been brought into the country today, if given appropriately 2 doses, 1 dose 7 days later, another dose, or at least 6 weeks later, another dose, you confer that community with 3-year immunity. In that 3 years, you are to embark on addressing the primary determinants of cholera. That requires a multi-sectoral approach. We need to galvanize sufficient political will to drive this multi-sectoral approach. We need leadership. We need evidence-informed leadership to drive the process. We do know that as we push towards control and elimination of malaria, outbreaks will arise. And the time that you have an outbreak, you must know that you are facing a public health war. In a functional health system, there is a pillar that we call public health security. It is designed to protect the country from public health hazards. It is supposed to be sufficiently resourced. They are supposed to conduct surveillance to detect threats to public health. They're supposed to ensure preparedness, early response, sufficient or effective response, coordination of all players. And that's the reason why the Zambia National Public Health Institute was set up in 2018. Today, where we are facing a ferocious public health war. The enemy is cholera. We must unite as a common front to address it. The command must formulate an effective and efficient strategy that will ensure, one, adequate human capital, logistics, surveillance, and efficient execution at the front line. When you have an enemy confronting your public health, you must fully understand that enemy. Today, the cholera outbreak we're facing here is fueled by consumption of contaminated water and contaminated foods. Therefore, in the community, we must invest in interventions to address those. How do we do that? Let's ensure that people stop consuming contaminated water. Put up water tanks in all the epicenters and the hotspots. Hyperchlorinate all the water sources in the country. Ensure that people are sufficiently sensitized to boil and chlorinate their water, even using household chlorine. Ensure that you ban street vending in the interim. Because consumption of food from the streets, fresh foods from the streets, will result in people getting, cholera. You must invest in sufficient measures to protect the public from getting infections. So you must cut the transmission cycle in the community. That's your first intervention. The tap at the moment is leaking. So you can't invest in mopping the floor when it's leaking. Fix the tap. Stop the new infections.
Right.
Give people fresh water. Stop consumption of contaminated foods. We must invoke the Public Health Act. The Public Health Act is sufficient to manage epidemics. If you invoke it, it confers the Minister of Health adequate authority to manage determinants of health even beyond the health sector, to coordinate with other sectors. And if that fails, you even escalate it to the Vice President's office, coordination level, even to the President's office. It is time for us to escalate the multi-sectoral efforts in the community and address the primary determinants, the primary factors fueling this epidemic. Cut the transmission cycle, stop the new infections. And as we do that, the caseload that is already there, we look at contact tracing to pick up early cases, cases early, treat them. Those that are treated at community level, you treat them. Those that you need to treat in treatment centers, treatment units, you treat them. Those at the cholera centers, you treat them adequately by deploying sufficient human capital, sufficient logistics. So two things you're doing, you are plugging the tap, stopping new infections, disrupting the transmission cycle.
Right.
For those that have already passed the barrier, adequately, effectively treating them. Indicators will show if your measures are working. If your BIDs are going up, your sensitization is inadequate. Your community interventions are inadequate. If your facility deaths are going up, you need to address your case management protocols. And you need to ensure that you have sufficiently motivated, adequate human capital with sufficient supplies. Zambia is endowed with a very well-trained human workforce in the health sector. Highly qualified nurses, doctors, environmental health officers, provide them with sufficient logistics. They will be able to provide health services across the continuum of care. They will promote good health, they will prevent diseases, they will treat, they will rehabilitate, and they'll provide palliative care. What we need is a functional health system that assures, one, health access to everyone, two, adequate infrastructure, three, human capital. We must ensure that there's adequate financing and that the supply chain for logistics is sufficiently addressed. Hearing of a body being picked from Cairo Road, dying from cholera, is a red flag. We need to ask ourselves if our interventions are working. If your numbers continue to show a surge, an increase in terms of incidents, in terms of BIDs, in terms of facility deaths, question your interventions. They might be right. There might just be a need for you to ramp up, escalate, be more aggressive. In a war, the command must be well informed, battle tested. The team must be carefully selected. You must mobilize sufficient human capital from across the regions of the country. Deposit the human capital, report, and make sure that you repose them with responsibilities, trust them with responsibilities to manage the hotspots, the epicenters. Monitor the data. See how the spread is going. People move. Are there any epi linkages to the epicenters? How do we disrupt that? How do we stop new infections from spreading to other areas? Zambia National Public Health Institute is a platform for coordination. This is a disease intelligence unit. It is charged with the responsibility to ensure public health security. They are to coordinate with various stakeholders in the spirit of a One Health approach and ensure that we leverage all our what we call a wealth of knowledge, expertise, and ensure that the public is protected from public health hazards. So today, the Zambia National Public Health Institute must rise to the occasion, escalate their abilities to coordinate with various stakeholders to ensure that this outbreak is brought to a halt. They should trigger the emergency response adequately. The human capital, laboratory services, logistics, research to ensure that you pick up factors that will inform any moderation of the response. You see, if you are going to take samples from foods that are being sold on the street or in the markets or from the drainages, and you pick out that the Vibrio cholera is there, then you know that you need to ask the minister to invoke statutory powers through the Public
At what
Health
point,
Act.
at what stage do you do that? Is this why I'm asking? It looks like we are not proactive. We know as a country when cholera most of the times comes into to be among us, and when is preventive surveillance supposed to be done?
Thank you for that very important question. Zach, in a functional health system, your focus is on health services for everyone. You focus on service delivery as your core.
Yeah.
These services that you're supposed to provide should be promotive, preventive, curative, rehabilitative, or palliative in nature. Even in times that you have no outbreaks, we expect aggressive health promotion activities, preventive activities. We can't be reactive. The reason we set up the Zambia National Public Health Institute is to ramp up surveillance to ensure we keep a tab on public health hazards and maintain high levels of surveillance. And if there are matters that must be addressed in a promotive or preventive nature, they are done. So, in the times of peace, you may not know that we will be vaccinating people in Sumbu fishing camp. You would not know that in 2019, when we had no cholera, we were vaccinating people in Kanyama. We're vaccinating people in Isumbu. We're vaccinating people in hotspots. Because you know the epidemiological profile of the country, the public health hazards the nation that faces, and you also know what are the interventions in the multi-sectoral cholera elimination plan. One, you address WASHE, that is infrastructure for water and sanitation, including hygiene practices for the public, but also while you're addressing that, you confer immunity in vulnerable communities. That should happen even when there's no outbreak. Okay, and as you pursue your sustainable development goals, moving towards sustainable access, universal access to clean and safe water, these things start falling off. That's the reason why we should consistently speak about giving decent housing to our people, ensuring universal access to clean and safe water. That will involve upgrading our slums. This should be subject of our national development plans. Now, you're asking at what point should it be done? It should be routine. This is the reason we re-engineered the health sector to include a directorate of health promotion, environment and social determinants.
Right.
That directorate, the role is to empower the public with information on how to maintain wellness, how to prevent communicable diseases and non-communicable diseases. That should be routine. I repeat, my steering call to government to reinstate that directorate because they've reduced it to a unit. And that just reduces, it dilutes the importance of health promotion in universal health coverage. Empower people with information and they will change their behavior and they will be safer. Don't drink irresponsibly, don't smoke, exercise adequately, make sure that the food you eat is healthy foods, you will save a life. Avoid obesity, you will save a life. Do not be happy to start treating myocardial infarctions, heart attacks, when you can actually prevent them. That's why your first port of intervention, of investment in the health sector, is engaging the public, giving them information on how to maintain wellness, on how to prevent diseases. The time that they get ill, it's because we have not adequately promoted wellness or adequately prevented diseases. There must be fewer, and those we must adequately treat in our health facilities. This is the reason I emphasize health services are not synonymous with hospital services. Hospital services are just a component of a continuum. Begin by ensuring people remain healthy, prevent the diseases, both the communicable diseases like malaria, cholera, HIV, and so on and so forth, and the non-communicable ones, diabetes, hypertension, cancers. So you can't underplay the importance of health promotion. While we call it health promotion, environment, and social determinants, we share one ecosystem with plants, with animals. And therefore, we must coordinate with other sectors that deal with animals, that deal with plants, to ensure that we manage this environment to protect human, plant, and animal life. That's the reason we talk of a One Health approach. The drugs we use in plant medicine, health medicine, human medicine rather, animal medicine, some antibiotics are the same. If we do not promote judicious use of these antibiotics, we will have resistance to these medicines. And then we'll have antimicrobial resistance, which is an existential threat to humans globally. Therefore, it is important that in the spirit of a One Health approach, we work together. That's the reason the Zambia National Public Health Institute has a mandate to coordinate with other sectors to promote a One Health approach. That's the reason the Ministry of Health must work in coordination with other sectors to promote a One Health approach, address primary health care determinants, housing, water and sanitation, nutrition, education, infrastructure. Then we will be addressing development, health, sustainably and holistically. and matters of cholera will fall off. When we debated the budget, we said on the floor of the House, there was inadequate provision for public health security. There was very little, if anything, for health promotion. We advised that in the absence of adequate provision for these two pillars, public health security and health promotion, the country was at risk of public health hazards that would derail our economic development program. It would cause the country to divert resources from other worthy sectors and now focus on protecting the public. But that would be reactive. It would be more costly. It would derail your economic development program. Let's learn to listen to each other. Let's work together and push towards a sustainable development agenda for the country. Invest adequately in public health security, address sustainable development, take a social determinants approach to health, address housing, water and sanitation, ensure nutrition, and focus on sensitizing the public, engaging the communities on promoting wellness and preventing illness. When we do this, matters such as cholera will fall off. So to answer your question in a nutshell, prevention is continuous. Promotive health services are continuous. When there is an accident of a disease, we must treat efficiently. If we are strong in preventive and promotive medicine, the numbers of cases we see will be fewer. That's why even in this outbreak, the focus should be in the community. Ensure people have fresh water, clean the surroundings, clean the drainages, stop the infections in the community, sensitize the public, bring on board all the community stakeholders, Street Vendors Association of Zambia. People will understand. If you don't do that, you'll start getting deaths on the streets, in the markets.
Now, I still want to understand, because obviously you mentioned that when you took the bold decision as a country, obviously at the time you were Minister of Health, when Zambia took a bold and ambitious step to eliminate cholera in Zambia by 2025, you obviously did put into consideration upgrading settlements, for example, and of course putting in place clean water, that settlements have, the upgraded settlements have clean water and all. But between 2019 and 2025, what was the plan like? Because I'm thinking that we probably crucified ourselves by giving ourselves this period, considering that most of our implementations of this were long-term. Why did we squeeze ourselves in within that time?
Well, thank you very much.
Was it attainable?
In 2017, 2018, we had an outbreak of cholera.
Yes.
It was declared in October 2017, and we declared it over in May 2018.
Right.
We knew what caused the cholera outbreak, and we knew what we needed to do, not only to stop that cholera outbreak, but to sustainably control cholera and move towards elimination.
Okay.
The first sign to show that we're on course is that in 2019 we didn't have cholera, 2020 we didn't have cholera, 2021. Okay, so now we have started getting cholera outbreaks. Again, what you should ask yourself is what has changed. One, there's something that we share in common. Everyone from previous governments share this view. Peri-urban areas in Lusaka are overcrowded. They need to be re-engineered, if not abolished. And people need to be given access to better housing, to better infrastructure for water and sanitation. Now, that is medium to long term.
Yes.
That's a common parameter in all these, in the various governments. But number two, what do you do in the immediate to protect the people that are already there? That's the reason why sensitization should be continuous.
Okay.
Number two, you need to know that there are shallow wells in there. Those shallow wells get contaminated just when we get the floods, just when we get the waters, heavy rains.
Yeah.
Cholera outbreaks are typically between week 40 and week 23 the following year. We're looking at the rainy season.
Yeah.
When you have heavy rains, the waters will move, the shallow wells will be contaminated from the pit latrines, from the poor sewerage management systems.
Right.
Now, so in the immediate term, you need to address access to clean and safe water. That's the reason why in NHIMA we embarked on a project to redo the water infrastructure. That project needed completion because we know NHIMA as a trouble spot,
Yes.
as a hotspot for cholera. So we needed to complete that. In the meantime, we also needed to recognize that the people of NHIMA were still vulnerable because not everyone had access to clean and safe water. So cholera vaccination programs needed to continue. We didn't need to stop it at any point. Sensitization, upgrade of or improvement in access to clean and safe water, cholera vaccinations needed to continue. Hygiene. We need to continue sensitizing the public, and we need also to ensure efficient programs to manage our solid waste. Our drainages are clogged with a lot of dirt, sometimes even fecal material. When flies set on that fecal material, and God forbid there is Vibrio cholerae on that fecal material, the same flies will settle on our foods on the streets, on the fresh foods. When we consume that, that's how we get cholera. That's the reason I'm emphasizing the need for laboratory tests.
Right.
You take the samples of foods on the streets, in the markets, in the drainages, in the toilets, public toilets. When you adduce evidence that these are contaminated, that should inform measures that will protect the public from that. Now, if you want your measures to be effective, involve the community, the stakeholders, the Street Vendors Association of Zambia, the marketeers, the traders. Where there are congregate settings, such as the markets, any other trading places, places of worship, these are potential areas of spread of infection. You must engage these key stakeholders, sensitize them sufficiently, and let them participate in the measures to stop the spread of the. We did shut down Lusaka CBD.
Yes.
We did bring in the security forces, the Street Vendors Association of Zambia, the marketeers, to clean up the CBD, to clean up those drainages. We moved even in the peri-urban areas. There is need for a mass campaign for cleanliness today. Clean up the drainages and clog them, remove all the waste that host the Vibrio cholerae. There is need for us to ensure that transmission is nipped in the bud. If we do not address solid waste management, cleanliness, access to clean and safe water, we will be mopping the floor at Heroes while the tap continues to leak in the community. The sage will continue. The mortality from both the community and the facility will continue rising. The numbers today are showing that we need to escalate the multi-sectoral response. We need to ramp it up aggressively. This is a war. It requires strategy. It requires sufficient human capital, logistics, efficient execution of the strategy, and we must keep a tab on the numbers. They'll show us if we are doing the right thing or not. The public deserve protection from public health hazards. And today, we're in a state of a public health war. It requires battle-tested commanders at the front line. Summon all these environmental health officers from the regions. Let them come to Lusaka, which is the epicenter. Ensure that we zone Lusaka very well. Charge environmental health officers senior enough, experienced, battle-tested, with responsibilities to enforce public health measures. Declaring them is not adequate. Enforcing is critical. The outcomes shall reflect the efficacy of what we're doing. The treatment centers must be manned by senior enough human capital with sufficient support in terms of logistics, and we must not allow patients to die out of dehydration as long as they reach the facilities. The efficacy of our interventions in the community will reflect through the number of cases that are coming through and through the number of BIDs. Cholera is both preventable and treatable. This path has been walked before. The script is clear. It's important that today we form a common front and face this scourge and stop the deaths now. Stop the new infections in the communities. Stop the deaths in the treatment centers now. And we will be all held accountable if we do not protect the public today from this public health scourge.
This is the Thursday edition of The Burning Issue. My guest is Honorable Dr. Chitalu Chilufya, Member of Parliament for Mansa Central constituency, and of course, his former Minister of Health. Now, there's been a back and forth on this issue and blame game on the cholera outbreak. First of all, you alluded to the insufficient funding in as far as sensitization is concerned. You spoke of the suspended continuous vaccination. Would you say that there was neglect on the part of government with regards being proactive on this?
Look, Zach, I'm not here to blame government. I'm here to
because
support government.
There's this back and forth blame between the people, the citizens, and the government. And of course, there's an issue of the people are being careless, and the people also are fighting back and saying, no, you haven't provided efficient interventions in as far as prevention is concerned.
Zach, I called for evidence-informed leadership.
Right.
And I'm not here to condemn government. I am here to provide support to the government efforts to stop this outbreak. And I come in good faith. And I hope somebody is listening.
Right.
And I'm saying cholera is both preventable and treatable. We have sufficient arrangements within government systems to respond to an outbreak. We can prevent it. If it does occur, we can manage it. What we're saying here is that the community is a principal stakeholder in ensuring community health and even in fighting a public health war. It is not time to throw blame to each other.
Right.
Across the political aisle, we must unite and face this as an existential threat to Zambians. Therefore, it is time for us to understand adequately the stage at which this war is. A public health war evolves. In October 2023, we're recording less than 100 cases in a week. In the week beginning 26th December, going forward, if you analyze the epi curve, we started seeing cases beyond 100 per week. In January, we started recording 400 cases per day. If you analyze that epi curve, it tells you that there are things that needed and need to be done in order to respond to the evolving epidemic. That's the reason data must be used to inform realignment in the response, reinforcement, scaling up or scaling down. So at the moment, we are in the surge phase. The cases are escalating on a daily basis. The numbers of deaths are unacceptably high. There is an urgent imperative for escalated multi-sectoral response in the community and in the facilities. In the community, principally, we must sensitize the public. Not time to blame them, but to sensitize them on the need for hand washing, escalated hygiene, personal hygiene, cleanliness in congregate settings, in household settings, consumption of clean and safe water, bury all these shallow wells, chlorinate your water. Let's hyperchlorinate the sources of water that we deliver to our various communities. And let us ensure that in all congregate setups, there is adequate sanitation. And where there is inadequate sanitation, stop those gatherings. This is the reason why I called for the timeless invocation of the Public Health Act, so that the minister has enhanced powers to clamp on any determinants that are fueling, any factors that are fueling the epidemic. That must be timeless. So you don't see a surge in October and start doing things in January. You must ensure that your disease intelligence unit is able to pick up red flags and advise on immediate escalation. And so it's not a time for blame game. We are where we are today. There's a surge. Deaths are skyrocketing. We must get into the community, aggressively address all the determinants, upstream determinants of this disease. Cut the transmission, stop the new infections, get into the treatment centers, treat sufficiently, and stop the deaths. We must unite now more than ever before and ensure that the public is protected from unnecessary deaths.
In an effort to have improved wellness of citizens, it was under your leadership that the National Health Insurance Scheme was set up. Just take us through what motivated that move.
If you focus on health services for everyone, everywhere, you must ask the question, what impedes this access to health services for everyone, everywhere?
Yeah.
You realize that one of the key barriers to access to health services is money. People do not have money in their pockets to go and buy a card, pay for consultation, pay for investigations, pay for drugs when they're ill. Now, in order to ensure that the issue of out-of-pocket payments is addressed as a barrier to access to health services, there was need for us to come up with an innovation to ensure everyone at any point in the month in their lives can access health services without the burden of paying out of their pocket. I am saying money, finances, was a big barrier to health services for a lot of our people. Bwanji baba mnaende kuchipatala, nishtamwaila kuchipatala. No, nilibe ndalama, zolipula buku. Iya wananuza nikaende ku x-ray kunalibe ndalama. Wama nishtamwaile tamwapokera mshutakuwa halimu kuchipatala, and so on and so forth. Addressing healthcare financing is critically important in your suite of health services for everyone, everywhere. So NHIMA is just but an innovation to improve healthcare financing, to ensure the health system is adequately resourced to provide health services for everyone, and that the public, the individuals, are not overburdened with the need to pay out of pocket when they're ill. We needed to come up with a system where you pay a little amount, either from your salary or from your earnings in the informal sector. That little amount should assure yourself, your spouse, your children, or your dependents of health services whenever you need them, both in the public and in the private sector. To be practical about it, you needed maybe 50 kwacha to buy a book. You need maybe 100 kwacha for consultation, maybe another 100 kwacha for x-ray, another 200 kwacha for various investigations in the laboratory, maybe for blood count. And at the end of the day, you spend more than 1,000, 2,000 kwacha for one consultation, for one visit, for one family member. If 3, 4 family members need to be seen, you spend 3, 4, 5,000 kwacha. That's about the salary of a person on average in the civil service or in the private sector. So it means that health services now would be driving poverty, would be pushing poverty. So to remove that, you needed to say, let's have just 1% of your pay. For one who gets 5,000 kwacha salary, you pay 50 kwacha. That 50 kwacha will assure you of health services, whether it's consultation, investigations, medicines, for you, your spouse, even your 15 children. Now, how does the maths work out? If you have 3 million subscribers to this scheme, in a month you probably have less than 100,000 who are sick, but 3 million are paying. So the rest of the money is supposed to be used to ensure that supply chain for medicines is improved, operations of hospitals are improved, and that in solidarity, those who can't afford to pay are covered. So the principles of NHIMA are: one, pooling of resources to ensure that premiums reduce; two, solidarity with those who can't pay; four, remove out-of-pocket payments as a barrier; five, finance innovatively and sustainably the public sector to ensure that they have extra resources to invest in service delivery for the public. That's the reason NHIMA was established. We cannot continue competing with other sectors from the common pot at Treasury for funding. It's not sustainable. You need to have an innovative, sustainable, and robust way of financing health sector. That's the reason the National Health Insurance Management Scheme was promulgated. It is part of a functional health system. I repeat, a functional health system focuses on health service for everyone. You must ensure adequate financing for it. And one way you do this is to establish an institution such as NHIMA to ensure there is extra resources in a sustainable way to finance health services. So NHIMA is a very important healthcare financing tool. And that's why today I bemoan the fact that it's been moved to the Ministry of Labor. It is supposed to be a financing tool for the health, for the health services, for all Zambians.
And the fact that you've mentioned it being moved to the Ministry of Labor, as opposed to keeping it under the Ministry of Health, just tell me, how does that change the whole essence of its function?
We must align NHIMA to the principal fundamentals of universal health coverage, health services for everyone, everywhere. Not health services for you, Zach, while you're working. Services for that miner while he's working. Health services for your children when they are not yet born, when they are born, for you before you begin work, while you're working, and when you retire. For everyone, everywhere, not just for workers. Practical examples of how capitalistic workplaces can be in terms of health sector provision are there. Osakili Mine Hospital, a number of these mine hospitals were full with consultations. Access was there for all our citizens in the mining areas. Why? They were children of miners, they were wives of miners, dependents of miners, and the miners themselves. The moment we privatized and those hospitals went into private hands, Some of those hospitals became white elephants. Why? You needed to be part of the workforce to access health services. But when you have a system where health services are prepaid for through those who can afford, and in solidarity for those who cannot afford or their dependents, you exploit the infrastructure for health that you have, and you'll have access to health services for those who are children, who are not working, who are working, and those who are not yet working. So it is not a matter that is just supposed to be addressing workers alone. It is the reason it was started by myself as Minister of Health and not by the Minister of Labor. It was about a functional health system. Anybody who is a scholar of health systems will tell you that health service delivery is you must have human capital, infrastructure, supply chain, healthcare financing, public health security, leadership and governance. You must have the data to inform planning. So this is a health system issue, and we must not regress by starting placing it in wrong places. As a matter of fact, by misplacing NHIMA, by undermining the fundamentals for which it was created, and for adulterating basic principles of universal health coverage, and just not having sufficient leadership for NHIMA and for the processes therein involved, we are putting NHIMA at the risk of insolvency. I say this because you must understand that pooling of resources requires that as you procure these services from various institutions, whether public or private, you also negotiate sufficiently the rates, the premiums. So don't have a situation where you collect less and pay more. You'll be tapping into your buffer, and in no time you collapse. This NHIMA is a healthcare financing tool to support financing for health service delivery. We started with the public sector. Yes, we brought in the private sector on principle. They are part of the health infrastructure we need in order to provide health services for the people. Premiums must be negotiated to align to what we collect. We must ensure that any foul play is addressed and addressed quickly through clinical audits, through audits. In the past, we had more than 80% of claims from NHIMA coming from public health institutions. Today, it's the converse. Well, more than 70% of claims are going to the private sector. That means that now we are resourcing the private sector more than the public sector in NHIMA. That requires re-engineering. These are things that must be addressed through effective leadership. We must address leadership and systems at NHIMA today to avoid collapsing it. It's an institution that is so critical for healthcare financing and must not be abused. And therefore, I am calling for streamlining of the functions and operations of NHIMA, of its associations with the public sector and the private sector. And I emphasize the need for both the public and private sector to participate in a manner that is mutually beneficial, or that is beneficial to that common stakeholder, the citizen. And no one should abuse NHIMA and push it towards insolvency. Let's retreat and get back to the basic fundamentals: pooling of resources, reducing of premiums, accreditation of facilities, public and private, claims properly and prudently done by public and private facilities. We should ensure clinical audits to avoid abuse. We must ensure service delivery in our public hospitals in order for the citizens to go to the public hospitals. If you don't have medicines in public hospitals, people will go to the private sector. And if they go to the private sector will claim more from NHIMA. If you don't have medicines in the public institutions, people will go to NHIMA accredited pharmacies. Then the NHIMA accredited pharmacies will claim more than the public institutions. If you don't have investigation ability, like today at UTH, where the laboratories are nearly collapsed, people go to private laboratories. And it means that it's those private laboratories who claim from NHIMA. The idea is the public sector must be sufficiently resourced to provide optimal health services. There is human capital that is already there. Provide sufficient support for pharmaceuticals, medicines, for laboratories, for investigations, to attract citizens to get into the public sector, and let the public sector then make those claims. In the absence of good service delivery in the public sector, you will skew requests for service provision, for health services to the private sector, and appropriately, there'll be more claims from there. That would then move NHIMA away from the fundamentals. I summarize this by emphasizing that both public and private sector participation is critical in NHIMA to improve access to health services. There must be appropriate technical leadership, and we must ensure that the public sector and the private services all have adequate services to ensure that people can access these health services at the right cost.
Dr. Chitalu Chilufya, Member of Parliament for Mansa Central constituency and former Minister of Health, is our guest today. The burning issue. Now, let me bring you to one critical part of this whole health sector is the Cancer Disease Hospital, which has been reported to be ineffective in some way. I mean, we have received quite a number of concerns about how the Cancer Disease Hospital has run down machinery, and of course that making it very difficult to provide cancer services. What's your thought on this issue?
Cancer is a non-communicable disease,
Right.
and the incidence of cancer globally and nationally is on the rise. Today, our Cancer Disease Hospital is seeing over 13,000 cases. Our cancers in the country recorded more than 13,000, and our CDH is seeing more than 3,000 cases. Cancer control is critical for the nation, and our Zambia National Cancer Control Program is premised on promoting wellness to ensure that people keep away from any risk factors, preventing cancers, and then for those who get cancer, to treat the cancers, and those who we cannot manage by the stage of the disease, we provide palliative services. If we fail to rehabilitate them, we provide palliative services. It is the reason why I will repeat my steering call for us to upscale health promotion in the country to address common risk factors for non-communicable diseases. These common risk factors not only lead to hypertension, to diabetes, they also lead to cancers. That's the reason why we should discourage smoking, abuse of alcohol. We should discourage physical inactivity, and we should discourage bad diets and use of certain chemicals. And that's the reason why we must be very loud about wellness. We must be very loud about wellness. We should prevent common cancers such as cervical cancer by ensuring that vaccinations against the human papilloma virus that is known to be an important causative agent is enhanced. We must ensure that we address other factors, debut, early debut, many other factors that are known. This is through promotive and preventive efforts. For those that we become ill with cancer, we must have adequate facilities to treat efficiently. That's the reason the Cancer Disease Hospital was set up. That is not the first port of call in our response to cancer. It is promoting wellness and preventing disease. For those who fall ill, we want to treat at the CDH. So the CDH is a flagship institution that has contributed to effective management of our cancer patients. Now, you see, you manage cancer in that institution either using medicines, chemotherapy, or use radiotherapy. Now, more than 60% of the cases that we see require radiotherapy. And because of late onset, late presentation, even a higher percentage of the cases that we see require radiotherapy. It is important that we have no disruption in the provision of radiotherapy services. You see, we have linear accelerators, bunkers, we have cobalt sources, we have all sorts of interventions that we use there in the cancer disease hospitals, that were part of the infrastructure and equipment that was set up there. Of course, the lifespan of this equipment may be 7 to 12 years. Some of that equipment has lived beyond that. However, we continued to maintain it. We had service contracts to ensure that those machines continue to work while we were pursuing reinvestment in upgraded equipment. There was a loan facility from a number of, like a coordinated effort through IEA, the Austrian government, and so on and so forth, to ensure that we replace the equipment. And there was also, other plans to replace the equipment using other resources. These processes are there on paper and we are progressing. In the meantime, we had service contracts with companies such as EML to ensure that our radiotherapy equipment continued to work. It was a mistake to stop those service contracts, to disrupt radiotherapy. We exposed patients that needed radiotherapy to premature escalation in morbidity and to premature mortality. You do not do that. What you do is to continue keeping the equipment functional while you continue with your programs to reinvest. So there's a seamless transition from old equipment to new equipment. There is even improved technology now. The improved modalities of providing radiotherapy. All these are on the scorecards. The previous government, the current government are pursuing that. But you don't surgically interrupt those services. So I am making a call on government to ensure that what we have there, we continue servicing it and continue providing radiotherapy services for people that require these radiotherapy services. We had plans as we head to send patients into Tanzania. We have not seen any patients reported to get into Tanzania. We've seen cases. We've seen reports of patients being sent to India. And I am stating here that our investment in infrastructure, in human capital, in equipment, in the supply chain was meant to stem capital flight through the referrals abroad. And for us to ensure that we remain on course, we must continue investing in our own infrastructure and equipment and in our own human capital. We're on course. CDH is now a flagship. CDH is a flagship institution in terms of training. We have students from outside the country who come to train here, and we have some of the most well-qualified oncologists and associated staff. Let's not drop the ball. Let's continue with the equipment, that is there. Service it. Let it be functional, and let us continue. In fact, accelerate the procurement of new equipment. It's not plug in and get. You have to place an order, then they start, manufacturing for you, and then you will probably get it 8 months, 12 months later, and they're like, that's the reason why in the transition you must ensure that there's some
They're well
continuity.
maintained,
Yes,
yeah.
yeah, we know the challenges that have been with our linear accelerators, with our bankers, and so on and so forth. But at the technical level, you know what can be done in order to ensure continuity. And so, what is obtaining at the Cancer Disease Hospital is unacceptable. The service delivery levels at that institution, are very low, and we need to do something urgently to ensure that our cancer patients get the optimum care.
Great. Well, Honorable Dr. Chitalu Chilufya, Member of Parliament for Mansa Central constituency, is our guest, and he is also former Minister of Health. And we have been unpacking everything around the health sector. And we will give you an opportunity as listeners to call in, and would encourage that we stick to issues that we have so far discussed. And let me give you one message that comes from Mansa, from precisely, to be precise, our partner radio station, Tuta FM. Says, morning, Doc. According to statistics from the Ministry of Health in Mansa, most water sources are contaminated with fecal matter because most residents depend on shallow wells for water in a place where most of the dwelling places are sewer self-serviced, in this case, pit latrines and soakways. Also, the CBD, which is in your constituency, has a couple of points where sewer affluent has been spewing for months. What is your comment on these issues which present imminent risks of cholera outbreaks?
Thank you very much. As part of our sustainable development agenda as a nation,
Right.
we need to address water and sanitation, solid waste management, sewerage must be managed appropriately. And if we don't, we're going to have contamination of our water sources and perennial outbreaks of waterborne diseases such as cholera and typhoid. It is a matter that we must continuously address. It's the reason why we bemoan the reduction in the WASHI budget for 2024. We are supposed to upscale our investment in infrastructure infrastructure for water and sanitation. We have a huge body of water in the country. We need to translate this into access to clean and safe water. We have sufficient knowledge in engineering, in sewerage management. We should be able to avoid individualized soakways and come up with, treatment plans for sewerage in our communities. This requires political will. This requires us to galvanize the communities and the support from partners to raise the resources and ensure we come up with this. This must be a continuous process. We have seen the investment in a modern water treatment plant in the Mansa, and I'm very proud of that project. And it has increased access to clean and safe water for our people. We need to ensure that we maintain the momentum and ensure that both water and sanitation issues are addressed sufficiently and sustainably. And this is the best way we're going to assure our people are safe from public health hazards such as diarrheal diseases such as cholera and typhoid and many others. So my basic comment is that in our Vision 2030, in our sustainable development plans as a nation, we need to unite in pursuit of sustainable development goals, such as universal access to clean and safe water. And we're sufficiently endowed with water sources. All we need to do is translate this into access to clean and safe water for our people. And we have adequately trained human capital to ensure that engineering for management of sanitation, sewerage, solid waste management is done optimally. All we need to do is to identify our priorities appropriately and invest appropriately in it. I've always argued that if you take a health approach to development, you will succeed. And don't argue with me, Zach. I'll not say like, your founder say you weren't there. Yes, I wasn't there either, but I'll tell you that it all begins with health. You must be born first, and you must be born in the right environment for us to ensure that you will be one alive and grow, have a healthy first 2 years, first 1,000 days of life, and ensure that you're protected from vaccine preventable illnesses, and then you will have the cognitive ability to learn, to get education, and become a productive person like you are today. And your biggest strength is just your health. Without your health, you will not be productive. A morbid population will not contribute to economic development. So if we convene on one point, that we must invest in a healthy population for a productive workforce, for us to drive our economic agenda, then we'll prioritize in investment in health. However, investment in health must not be understood as investments in just medicines and our hospitals, but in all the determinants of our health. So we must perceive health comprehensively, promoting wellness through engaging the public on how to maintain wellness, preventing diseases, prevent malaria, HIV, preventing all these other diseases, and then invest adequately in curative services for those who get ill. So I call for a social determinants approach in terms of investing in the health of our people. Then we'll address all the primary health care determinants, such as water and sanitation. That is the topic of today, and indeed many other determinants that we can talk about later, such as nutrition, education, infrastructure, and so on and so forth.
Doc, let me take a few phone calls now. Good morning and welcome to the burning issue.
Yes, good morning.
Morning to you. Your name and where you're calling us from?
You are talking to Comrade Chilonda.
Mr. Chilonda, please go ahead.
Good morning, the Mansa Central MP.
Mr. Chilonda, good morning.
Who succeeded after that, Kenneth Sakeni. Succeed Kenneth Sakeni, who died as a Minister of Information. Yeah, you come from...
Please go on and make your case. We don't have enough time, please.
Yeah, the only issue, the point what I would love to say, we have a poor drainage in the city. And since UNIP, we have got the Lusaka City town planning, which does not exist, just on the paper. And that's why we've seen more floods. So what we need, even in the lawlessness, the way we are building houses, we need to build houses in order. Make sure that there's good drainages, and make sure that the houses is in order, good streets. Now you are building on the pipe of water and saying good here. No, that's lawlessness. That's why you have seen this disease. So what we need is to work together. There's no political issue here. It's about to fight this disease. All of us to stand up. I think, thank you very much.
Thank you. Thank you so much, Mr. Chilonda, for your call. And of course, you too can call us on 0955 221515. Those who would like to send us your messages, please do so on the following number: 0761 912493. 0761 912493 for your messages. Otherwise, your phone calls on 0955 22 15 15. Let's take this one. Good morning.
Bazaki mabukashana.
Nabuka febwino kati mabukashana.
Nabuka bwino neliwirira nda don't busy kuchingora.
But don't busy kuchingora konkanyeni.
Honorable stroke doctor. Mutende mkwai. Mutende kana besa. Emkwai honorable wandi yeso ndandire stroke ba doctor. Mwali bombere ku chituwa cha bumi. Mwali bombere usaka busungu sana kulingana n'efyo twaremo na lero na mwisho wa problem yo tufikirepo kana besa ilili ashiria ya Cholera. So therefore asinomba mu take of encourage abako health workers, abako health sector, especially hapa lina ba permanent secretary kubika pumukwa na ba minister. kurolekesha mufyo twingalusha namakokwe bachipinga chimfya i problem because imwe muli ba doctor kuchiputula chavumi kushe kwena kana besa tukachimfya lilani uno mzambi obubulwe bwa Cholera kana alapone na mukira mwaka as a you doctor ile mwapitire kuchiputula chavumi kushe mube tontonkanya poshani kwe bachipinga bombera chapamo ukuchimfya ama problem na kabiri twike sa kwato obubu afya then season nga yali ishiri. So number 2 ndefo kuipushako bushecha ishirere ngokwa chimuchite introduce NHIMA kweba twambe kokulalipira ma chitomo apusana because ndemona kwati NHIMA nangu tulipira indalama batwibira sitapali nangu fimo syo effort gaining waya kunima oli amusanga chi imichita kuli bali amukweba chikalie ka chitomo ti instead yo bali kuputwire indalama bakuperi omuti akodi na marwele bakusangire na yena ifi yakulyana fina tatupoke ifi abayi nafu kulingana na NHIMA tubomba nomba ni chinyime cyarengere kwe bati mwirete cyari pushani mushekana besa natotera bombe bwi
Tatasha Mkwaiba, Don Busy from Chingola. I've got an interesting message here. There are reports. Again, this one is coming from Tuta FM, our partner. There are reports of high numbers of COVID-19 cases coming out of the Copper Belt province, with Provincial Public Health Specialist Christopher Dube disclosing that the area is experiencing a surge in COVID-19 cases, recording 100 new cases on average every day. Are you concerned by such developments? And being the immediate past health minister, do you think the country is equipped to better contain COVID-19 now? And obviously, maybe amidst the fact that we are also fighting another epidemic. I mean, it's quite a tall order, I know so. But let me give you one more phone call, and then you can respond. Good morning.
Good morning, Jackie. Mwashuke ni wa Dr. Chitalu.
Good morning.
Nine Dakra Singoni Kuchingumpa.
Mamuni. Konkanyen Pomkwai. Hello? Hello, Mr. Ngoni, are you there?
Yeah, kushirisha.
Wanguni Chilufya mkwai ambaye futi ipshe.
Mkwai?
Chilufya network ya chipena twachumfoko mwachambira comment.
Ba doctor, usheta mwashire ama documents ya kwa ndati. Cholera vaccine equal after 3 years. Ukwe ba health minister ba civil from 2018 after CS 2021 wafile basaba state abantu nabambi ushita kwa institution memory ya kulanga wati abantu bafile vaccinated to wipe away cholera. Mule keresha wa health minister, they did take care. We had to import cholera vaccine. After all, but for World Health Organization, this government broke, cannot buy a cholera vaccine. Where are we going as a country? Last year, Chilufya, Mulera and the Pushani, Padi Cholera, Gaisa, Munomchingola, that Patu and Para bus station, Yalo came full. Ameshade Kadira, Umendo, Ufido Kolopa, Amesi, State, Takolopa. Umrimendo filokolo amezi chiwala takolopa ushe tukalai karashani pade kolera abantu pade amezi na ekalira kansu taikwete indaram kunokuwa wondikala ya kusaidi kuno ifishara ya all over next to kasesere mining uko abantu bapote vishozo just 15 meters away from the houses vishozo kuni full bapote flora abantu tabakuza bakanzo. Where are we going as a nation? Where are we gone wrong as a nation? Please answer my question, Doc. Damwashire institution memory kushadi bafiro kula vaccinate abantu continuously. Thank you.
Thank you very much as well, Wanguni. I think I'll let you now respond to these concerns raised. If you could be brief in your responses so that we can get some more.
Combine my responses to the issues of cholera to from both callers who asked about cholera.
Right.
Let me begin by thanking the callers for this very pertinent question.
Right.
Like I said earlier, we came up with a multi-sectoral cholera elimination plan. Multi-sectoral. There are things that the Minister of Health had to do, the Minister of Local Government had to do, water and sanitation had to do, the community, and other stakeholders. There is coordination that is supposed to be happening at the highest level, at a very high level of the VIP's office. There are interventions that have been mapped out clearly in the multi-sectoral cholera elimination plan. What we need to do is get back to the basics. Ensure that we don't lapse on any of those fundamentals that are outlined in the multi-sectoral cholera elimination plan. It is informed by what we submitted to the UN as our submission, as our contribution to the global efforts to eliminate cholera. Zambia subscribed to the fundamentals of the Global Cholera Task Force, Global Task on Cholera Elimination, Control and Elimination. And our president today is recognized as the champion for cholera control and elimination. We must ensure that we don't drop the ball. We stick to what we wrote in the multi-sectoral coordination plan or improve upon it, and also ensure that we continue in the spirit of what is provided for in the Global Task Force for Cholera Elimination. Critically, it's about addressing access to clean and safe water and hygiene, wash. That is a multi-sectoral point of convergence. We must ensure that the infrastructure that we build has provision for sufficient sanitation, for sufficient access to clean and safe water. It involves various sectors. We must ensure that the sources of water for use in our communities are safe. Now, in doing all this, Zach, what we call monitoring the quality of what we should call generally surveillance, monitoring the quality of the water that our people are consuming in the various areas of the country is important. The reason why we zoned Lusaka into a number of zones was to create public health teams and clinical teams in particular zones. One, to promote wellness and prevent diseases in particular zones, and also to treat in those zones. We upgraded Chilenje, Kanyama, Matero, Chipata, first level hospital, clinics into hospitals to provide clinical services for the people in those areas. But critically, we also placed public health teams led by public health specialists to ensure that they did community level interventions. Water monitoring. Water monitoring is one. The quality of water that people are consuming in those areas would be monitored on a weekly basis. If you pick out coliforms, that would be a red flag, and you would actually warn and say there's a potential outbreak. Then you would actually react by chlorinating that water or addressing the source of contamination. Engaging the public in markets, in various congregate settings on how to maintain wellness. In other words, ensuring that people are well before they get into those clinics. But also those hospitals were capacitated in terms of infrastructure and equipment to stop referrals to UTH. That's how come UTH is decongested. That's how come UTH has no floor beds. That's how come you can now deliver in these hospitals around. But getting back to the point, I am saying that to eliminate cholera, it is important that washer infrastructure is addressed, and we should ensure that as we address the infrastructure for water and sanitation, we protect the public using cholera vaccines, but we must sensitize them on the use of clean and safe water, provide it, and sensitize them on the use of it, ensure that in places where we have inadequate sources of clean and safe water, either we augment or even improve on it by hyperchlorinating or using chlorinated or boiled and cooled water in those homes. You know, coordination with partners in those areas extremely important. The churches, the traditional leadership, the schools, a coordination, very, very important. And surveillance for any hazards must be enhanced. That's why in time of peace, when you think all is well, Zach, there should be health workers who are doing surveillance to check if there is any threat to your health, either through COVID or cholera. That's the reason we always call for increased investment in surveillance, public health security. So to control and eliminate cholera, address issues of slums, let's upgrade them, improve the infrastructure, or give them decent housing elsewhere, improve the current water that they're using. Sanitation must be enhanced. Sewerage management must be enhanced. We must clean. Cleanliness must be the gold standard. Where people are congregating, there must be access to clean and safe water, and sanitation must be good. Toilets must be there. Let's not allow people to congregate in just in any place. Let's only congregate in places where there's adequate water and sanitation. We will eliminate cholera that way.
Let's go to the COVID issue. I have a similar question, but this one is from Chitalu in Chingola, who says, while Zambia grapples with cholera, COVID-19 is on the rise. How can the situation be handled in view of an epidemic that the country is facing? What is his view? What is your view, in short, of how the government has actually handled the rising cases of COVID the last few weeks?
We must enhance our surveillance to ensure that we detect cases early and treat them. We must also cut transmission in the communities. So the data that we are adducing from the surveillance activities should inform what measures we should put in place. Again, ZNPHI comes in handy. We must have adequate opportunities, adequate provisions to do surveillance, pick up cases countrywide early enough, treat them, make sure that we cut transmission in the community. And we must ensure that the people who are not yet vaccinated continue to be vaccinated. Those who are picked up early as cases must be treated adequately and must be discharged to the community only when they cannot transmit cases. So my view is that we should enhance surveillance today, pick up the cases early, treat them adequately, do not allow poor or late diagnosis. If your surveillance activities are poor and are inadequate, you will see a surge in your facilities and you'll have difficulties to manage them. It is cheaper to get into the community and invest in early detection and in prevention measures. You will reduce the cases. If you think that is costly, check what it will cost you to create bed space to treat and check your morbidity and mortality in your facilities.
Let me move to my SMSs here. Morning panel. Dr. Chilufya, as one of the architects of NHIMA, are you happy with its performance? And if not, why? This is from James in Lusaka. I've got a second question in the same line. Mushe, wa honorable Chitalu Chilufya. Chinchi charengere ukutila wa government. Muleteko NHIMA. Pantu NHIMA, tapali efyo ile chita, bali afe mpia shavantu. Nine Don Busy Kuchingola. I think Don Busy called us, but also sent that message. Thank you very much, Don Busy, for that. Good afternoon, Zach and Honorable Chitalu Chilufya. I have heard an argument from people who feel NHIMA should be left to the Ministry of Labor because when it is removed, it is going to lose funding from those NGOs supporting it. For being in the Ministry of Labor. Can't it find support, in brackets funds, when it is moved to the Ministry of Health in this case? Could it be the reason why people find it difficult to access services from NHIMA because it is placed in a wrong ministry? Josta Moya from Lusaka. Thank you, Josta, for that question. maybe let me also add a few phone calls to those concerns. Good afternoon, and oh, it's still morning. Good morning, and welcome to the burning issue. Your name and where you're calling us from.
Yeah, this is Philemon from Chitulika, Zambia.
Philemon, make it brief. Please go ahead.
No problem. In fact, I'll be very brief. A lot have been made, have been spoken there by your guest. Good morning, Honorable. This one.
Honorable Chilufya, please. Yes.
Yes, it's good morning, boss.
Good morning.
No, I'm tempted to go, boss. I think you have Makamba once. I think if Mr. Bai is listening, I think he will call you. You have spoken sense, no politics. I think may God bless you. We are listening. Continue doing what you have spoken there. May God bless you. Thank you.
Thank you very much for your call, Philemon. We'll take some on 0955 221515. That's the number you're calling us on. And for your messages, it's 0761 912493. Let's take this call. Good morning.
Good morning, sir.
Good morning. You are very low, sir. If you could speak up, your name and where you're calling us from.
Yes, good morning. You are speaking to Patrick from Care for Generations organization.
Care for?
Generations.
Care for Generations.
Good morning, Doc.
Morning.
Yeah, first and foremost, I would love to appreciate the way the Honorable is conducting himself as a leader. We really want that. I would just quickly want to address on the matter that the Honorable MP is addressing. Matters to do with community sensitization. I think really the government, civil society organizations, community, and leadership, we have a lot to do when it comes to sensitizations. Looking at the issue of cholera, just like the Honorable MP is highlighting, it's a treatable and preventable disease. Really, if we had taken much time and resources to invest in sensitization, some of these cases maybe would have been reduced. Looking at the fact that it's just a matter to do with taking of health food, health water, and health environment. So if such information is given to the communities, meaning really a lot can be done and such cases can be prevented. So it's really high time that the government, local leadership, civil society organization join hands to make sure that sensitizations on various health matters are taken. Then also our councils.
Be brief, because of time, sir.
Okay, let me end here, sir. Thank you so much. Keep it up, Honorable MP.
Thank you. Thank you very much for that. Let me take another call on 0955 221515. And your messages are coming through on 0761 912493. We'll be taking the last three calls, then we should be done. Good afternoon and welcome to the program.
Good afternoon. Thank you.
Great. Your name, and where are you calling us from?
I'm William CEO. I'm calling you from Mondola. Good morning, Dr. Chilufya.
Good morning.
Thank you. I just wanted to find out, Doctor, would you declare that the 29th January, the school calendar safe for the school-going children and the teachers, looking at the prevailing situation in Lusaka, because the cases are not going down in any way. So what guarantee is there that the schools will be safe in terms of cholera-wise on the 29th? Because you have been there, so you know the measures that are supposed to be taken for the schools to be safe. Thank you.
Thank you very much, William, for that from Mondola. We appreciate your call and question. I'll take two more calls. Good afternoon and welcome to the program. Hello. Tulifia wino larisha mlanche komkwai.
Chitalu Chilufya yo the director recover malaria.
Okay.
Ndifya wino mkwai mulishani.
Wino. Nga kudi umuntu wabombere bwino ni Chitalu Chilufya. Kweosi. Izo ngati ni jife politics yabafye. Bada Chitalu Chilufya bali ngirofye kubachita adopt again babwera se kweosi. Me naliduwede Cholera nda PF lijum nali muirozi mulia but ilo yanjiketeshe luchero naitwala nemwine nshatalile andukapo rafe kudailia there were caring us our PF if yakulya uluchero ngabwacha keya uko yadeba ninkonde mwadia sawa every time ama apology yadeisa. So government, if we labor very consistent, especially in health, ama diseases, yes, as yapanapa, because in a remote sometimes this is what I'm crying. Quite in Zambia, the talk what mama machine I have a powerful. Actually detect ama disease wangu because it ingi nanangubana mkasango mwana kunganda ade pwashi okumutola ku hospital tamuli malaria but ade ondro kafe but abalisanga mobulwele. You see. So, like Chitalu Chilufya, they worked very well. Look at the hospitals, the level 1, Chipata level 1, Oshoba Butukire Apanapa, Chitapu grade. Those are people, abantu bamufire muri bwesha mu ministry bambokwa for government. But don't give a distance if you are paravena Chitalu Chilufya. Those are many. Yeah? Bafire bare bomba adequately na government ilipo. Abantu abakola pera ne Miran. It's only that the man in an arrested we can appoint him as the president of PF. Because that man, even in Ango, how he addresses the press briefing, you can see that is very reachable to
Natasha, otherwise Marandi Pilano Mambo Kula Chitira campaign by Chilufya. Tenshita campaign to Natasha.
I love that man.
Natasha, thank you. Right. Let me just give you a few. Well, I should take the last call, by the way. Let me see if I can take the last call, and I'll just read a few messages on Facebook. Let me quickly read them through. Muzilima Kamula says, it's a breath of fresh air to hear from you, Honorable. Long live. This is from Chazanga. Albright. Says, good morning, Zach and Honorable. You are articulating very well, and you are sounding as if you are still holding the ministerial position as Minister of Health. And let me just read the last one from Chari D. Sisulu. Sisulu says, well spoken, Honorable Dr. Chitalu Chilufya. You are a good example of a good leader. Please let the current government tap something from you and your vast experience, and that is in the health fraternity. Thank you very much for those messages. I thought I should read them out. We are almost coming to a close of the program, Honorable. I would like you to probably respond to those that you feel need response.
Thank you very much for the kind remarks from the callers, and I don't take it for granted. I appreciate Philemon Chitulika to letotela na bonse abatlatuma mafoni kulanda pa milimo ile bombeka ne milimo ya bombeka kunuma tulipanshi tutasha ichakubalira po Zach. Patrick for Care for Generation is talking about community sensitization. It gives me an opportunity to emphasize the need for us to ensure that service provision is done across the continuum of care. Service provision should not be at hospitals or clinics. It should be in the communities, in the markets, in the churches. This is done through health promotion. Disease prevention, indoor dual spraying, to prevent malaria, many other interventions such as vaccinations to prevent cervical cancer, engaging people in workplaces to avoid high blood pressure and heart attacks, strokes, to avoid diabetes mellitus. All these are health services. They are not in hospitals. They are done in workplaces, in the communities, in congregate settings. This is the reason why we should ramp up health promotion activities in the ministry. Even as we do recruitment in the Ministry of Health, we should not only focus on recruiting health workers to treat patients in hospitals and clinics. We must recruit public health nurses, public health officers, public health professionals to support provision of health services at promotive and preventive level. And therefore, I am urging for a balanced investment in human capital for health service provision across the continuum of care. We must not underrate the value of engaging the community and empowering them with information on how to maintain wellness, to prevent diseases. There will be less sick people in the country, and it will be cheaper for government. Let us invest adequately in public health security. Let us not be reactive, but let us be proactive. Ensure that the Disease Intelligence Unit, Zambia National Public Health Institute, is sufficiently financed to coordinate a One Health approach to health, coordinate with all other sectors that manage various determinants of health, and ensure that we address primary health care determinants of our health, housing and sanitation, water and sanitation. Let everyone ramp up the multi-sectoral response in this outbreak of cholera and beyond so that we move towards control and elimination. The outbreak of cholera in relation to opening of schools, every epidemic must be assessed as it evolves. Data that is being adduced or that is coming out from the communities, the facilities, in terms of new numbers, new cases, in terms of BIDs, facility deaths, these are important parameters that should inform you on how the epidemic is evolving. And so critical decisions of this nature should be informed by the evolution of the epidemic. So as the government ramps up its interventions in the communities and we start seeing reduced cases and reduced deaths, the government may then look at critical indicators, critical parameters such as when schools should reopen. But the importance of data management to inform decisions extremely emphasized here. And also the importance of laboratory diagnosis to monitor the trends. We must be able to look at our epicurves, make sure that we monitor the trends of the epidemic. As we pick out cases in various parts of the country, we establish the epilinkages and ensure that we make decisions informed by invocation of the Public Health Act to ensure that we protect the public. On NHIMA, abantu bakwalesa chintu chikankalangaje. NHIMA eyalenga okutira abantu baleka okukongolo olupia abantu balefa okuya ku India okuya mukwata operation nangu balefa aya okwatako ubundapishi bumo uwakutira tabalekwanisha okulipila. Oftentimes people used to borrow money in order to secure certain surgical operations, certain medical operations, both locally and internationally. You prepay a small amount of money in NHIMA, you have access to dental health services, ophthalmology, optometric health services. You will be able to access cancer medication. These are things that you were not able to do. Even just the basic consultation that you're not able to do with a prepayment of 30 kwacha, 50 kwacha, depending on where you belong, you'll be able to access NHIMA. However, there's a catch to it. The public sector, the institutions where people are going to seek services after they pay must be adequately resourced with medicines and with human capital so that people appreciate NHIMA. People do not appreciate paying for a service when the service is not there. Let us ensure we provide adequate medicines in our health facilities. Let's not talk about availability of medicines at ZAMSA. Let's talk about availability of medicines on the shelves in our clinics, in our hospitals. Let people appreciate that the 50 kwacha that they paid at the beginning of the month, they were able to access health services across the continuum of care. In your living room, we would like to see you, a NHIMA sponsor, we would like to see Zach hearing a NHIMA-sponsored message on how to avoid rheumatic heart disease in your 7-year-old child. Treat your child with a sore throat adequately with a penicillin to ensure that they do not get rheumatic heart disease. This message is brought to you by NHIMA. That way, NHIMA will be avoiding sending a child to theater at the National Heart Hospital for operations, which is more costly. And therefore, would like to emphasize the need for the Ministry of Health to up the game in health promotion. The re-engineered MOH that brought up a health promotion department was in response to what we saw on the ground. The case fatality today is highest, top 10 in cardiovascular diseases. What's the best response? It's not in the way we manage myocardial infarction, no. It's attacking the risk factors in the community, in the homes. And that way you reduce people who are at risk of getting those non-communicable diseases. NHIMA is a high impact intervention. It was crafted in the Ministry of Health as a response to our challenges in healthcare financing and let government realign to the fundamental principles of NHIMA. It was started in the Ministry of Health. There's no risk of any loss of funding. That's where it is started from. And contributors to NHIMA are the Zambians, the citizens, the workers, the informal workers, the businessmen. And this is the best way to establish a robust, sustainable, and innovative way of financing your healthcare. And you can finance these health services not only in our hospitals, but along the whole continuum of care. Let us ensure that we galvanize sufficient political will to invest in a strong health system that focuses on service delivery, universal access to health services for all, adequate infrastructure to create access for health services everywhere for every Zambian. Let us ensure the supply chain is sustainably fixed. The drug fund at ZAMSA, sufficient provision of funds to ZAMSA or to Ministry of Health procurement for procurement of medicines, timeless procurement of medicines, availability of these medicines on the shelves in our facilities. This will show through outcomes, through feedback from our patients. We don't need to scream. This will show. Let us avoid screaming statements on availability when what we see on the ground is different. Let us ensure that we invest in balanced human resource to promote wellness, prevent diseases, public health staff, and clinical staff, rehabilitative staff, and palliative providing staff. Let us ensure public health security, shield the public from epidemics. In a time of peace, let our surveillance be heightened. Yes, so that we pick out COVID, prevent it, pick out cholera, prevent it, prevent these outbreaks. And when we pick them out, detect them early and respond effectively to it. Let us coordinate with all stakeholders, WHO, UN agencies, our various embassies, the World Bank, JICA, USAID, many other cooperating partners of goodwill that are able to support health services strengthening, health system strengthening in the country. And that will conclude. On the note for cholera, we are in a state of a public health war. Let's take responsibility as a nation. All citizens across the political aisle will unite to form a common front and fight it. The numbers of people getting sick unacceptably high, death toll unprecedented, too high. We need to ensure that at community level, we wash our hands, stop handshakes, avoid overcrowding, make sure that we consume water that is safe, either using household chlorine or water that is boiled and cooled. Let us ensure that we work together in the communities to address those factors at individual level that may stop us from getting contaminated. And as a health system, let's intervene in the community and cut transmission. Provision of safe, fresh water is urgent. We need to cut the transmission. Let us embark on a massive cleanup campaign in the CBD, in the markets, in the epicenters, in the hotspots, and countrywide. Cholera in Lusaka is potential cholera in Luapula, is potential cholera everywhere. Cases will be epi-linked to Lusaka epicenters because of the movements of people. It is important that we trigger emergency response systems and preparedness in all parts of the country. Let us ensure that we cut transmission in the community, stop the new infections. Let us invest adequately in cholera vaccinations for the moment as we address water and sanitation infrastructure. There were 1 million doses of vaccines that came in, commendable. They're inadequate. We need to bring in more to ensure that for vaccine, for the first phase, dose 1 and the dose 2, we are able to provide that. I know we need to address the global logistics challenges, to do with that. And as a united front, we should be able to not only this war, the cholera epidemic, move towards control and elimination, and stay in our position as cholera control and elimination champions globally.
Honorable Dr. Chitalu Chilufya, Member of Parliament, Mansa Central constituency, and former Health Minister, I would like to thank you so much for making it. I know that you traveled all night from Mansa to make sure that you were here on time. We delayed slightly by 20 minutes in terms of starting the program, but I'm not taking that effort that you've made lightly. Thank you so much, and I can only wish you all the best.
Thank you very much, and thanks for the listeners, and thanks, Zach, for this opportunity.
Great. Well, listeners, thank you very much for having followed our conversation, and of course, for those that managed to participate, we're grateful for the effort, and thankful also to our partner radio stations that carried this program live, and that's Tuta FM, Muchinga Radio, iWave, Spice FM, and Wave FM. We will definitely be back next week with our Tuesday and Thursday editions of The Burning Issue. From us is take care of yourselves and more so of each other. Bye-bye.
Tune in next week for another edition of